Chapter 35, HIV and AIDS-related drugs. I don't want this chapter to scare you. There's a total, including this slide, of 3 slides. There's not a lot for you to cover in this. This is not a lecture on HIV and AIDS. You get that in your Med-Surg class. This is just about the medications. The only objectives, if you look on your objectives for this unit, the objectives that relate to this chapter are simply describe the classification of antiviral therapy and then also the nurse's role in medical management and issues of adherence. So I have broken this chapter down, and these are the 6 classifications, because one of your objectives is understanding the classification of antiretroviral therapy, or ART. You might see HAART, which is simply highly active antiretroviral therapy, which is when you're doing multiple combinations, which I will mention. So I'm not sure if you've covered HIV and AIDS in your Med-Surg class yet, but I'm sure it was touched on when you took pathophysiology and possibly even in micro. So I'm just going to say a couple of things. That HIV is now considered a chronic illness rather than a disease of death. More than 30% of the United States population that has HIV or AIDS are age 50 or older. And there are problems that come with aging as far as your whole immune system and other diseases that make management and complications increase. As we've come up with medications, drugs to combat this, of course, there is an increase in drug resistance. There's also an issue with adherence because they may be on multiple drugs and stigmas and other factors, which we'll cover with the nursing process. The goal is to reach a greater than 95% medication adherence, but right now it says we're at a 6 to 16%. So, studies suggest that there's a 6 to 16% of patients who are naive to antiretroviral therapy and have pre-existing genotype resistance. The problem with resistant forms is that resistant form is passed on, and so even though they're naive or have not been on antiretroviral therapy, they already have resistance, makes the management more complicated. So HIV is an RNA retrovirus, unable to survive and replicate unless it is inside a living human being, as we've discussed viruses anyway, needing that. The HIV destroys the CD4, which is critical in the role of human immune response through recognition of infections and neoplastic processes. So obviously when they have HIV, their risk for infections, all types of infections, and neoplastic cancer development is higher. They monitor the CD4 cell count, and it is an indicator for immune function. After the initial infection, there's a rapid viral replication and high level of virus in the peripheral blood called a viral load. There is a corresponding drop in the CD4, which triggers an immune response, resulting in the CD4 replacement in HIV antibody production. Almost all patients seroconvert or become positive in their blood within 6 months. They call this delay between exposure, infection, and showing positive window period. Patients who are at risk for HIV infection and test negative should be counseled to have the test repeated in 3 months. AIDS is a diagnosis that indicates advanced disease. So just move on, go all the way over to page 473, indications for antiretroviral therapy, or ART. Antiretroviral medications are changing rapidly. That's why what you just kind of focusing on these classifications. Let's see, classifications of antiretroviral medications. We're going to start with the first classification on the bottom of page 474, the NRTIs. They result in an inhibition of viral replication. It is preferred that there is dual or combination using tenofovir and emtricitabine. I can't even say things, isn't that terrible? All NRTIs except didanosone should be taken with food. So consider NRTIs. You need to remember they're taken with food. You need to watch for renal insufficiency because you have to adjust the dose down if they have a decrease in renal function. They have a lot of GI effects such as nausea, diarrhea, abdominal pain. All NRTIs are associated with changes in the body's metabolism. Complications include peripheral neuropathy, myopathy, which is muscle pain, pancreatitis, and lipoatrophy, which is a wasting of the fat in the extremities, face and buttocks. Rare fatalities, uncommon to have a drug interaction. Go on to the next, non-nucleoside reverse transcriptase inhibitors, or NNRTIs. What do you need to know here? They prevent viral replication by competing with binding of the reverse transcriptase enzyme at the active site. Primary advantage of NRTIs is to reserve protease inhibitor-based therapy for future use. So trying to use NRTIs before they have to go on to the next class. Major disadvantage are the prevalence of NNRTI resistant viral strains and a great potential for drug interactions. They can cause a lot of central nervous system toxicity. That's all I need you to focus on those. Go to the third class, protease inhibitors, which you'll find on page 35-2. These protease inhibitors sustain a viral suppression, improve immunological function, and prolong patient survival. There are 9 PIs, or protease inhibitors, that have been approved. Unlike the first one, the nucleotide reverse transcriptase, or NRTIs, and the NNRTIs, these protease inhibitors act at the end of the HIV life cycle to target viral assembly by inhibiting the activity of the protease, an enzyme used to cleave nascent proteins for final assembly of new virions. So what it's saying is it results in a formation and release of immature, defective, non-infectious viral particles. So that's why it works so well. This is very unique. When initiating the therapy with this protease inhibitors, there's a lot of gastrointestinal effects such as nausea, vomiting, and diarrhea, and they may have a direct impact on adherence. There may be an elevation in cholesterol and triglycerides, insulin resistance, and diabetes development. Atazanavir is the preferred protease inhibitor for initiating ART, or antiretroviral therapy. It has not reported having insulin resistance and is less likely to elevate cholesterol and triglycerides. And if you notice, atazanavir has that VIR, or viral part component, in its name. Move to the next one, entry inhibitors. The only approved one is efunviritide, which again has the VIR in the name of it, acts by a mechanism that inhibits GP41 fusion. What you need to know is it prevents HIV cell entry, which is significant, targets the prevention of the fusion of HIV and the CD4 cell, preventing passing of the viral genome to the CD4 cell. It is indicated only in combination with 3 to 5 other antiretroviral agents for patients with limited treatment options. So entry inhibitors would be something used down the line, and it must be taken subcutaneous injections, and it's very expensive. This CCR5 co-receptor antagonist, the only agent approved is Maraviroc. Again, it has the VIR in the name. It prevents viral replication. It must be combined with at least 2 other antiretroviral agents. Effective in 50% of the patients that have a resistance to most others. So you'd remember the CCR5 co-receptor antagonist, or CCR, yes, as being preventing viral replication, used in patients with resistance to some other antiretrovirals, used in combination with at least 2 others. This is for treatment-experienced adult patients with evidence of viral replication and HIV strain resistance, which I just said. Common side effects: cough, pyrexia, upper respiratory tract infection, rash, abdominal pain, dizziness, possibly drug-induced hepatotoxicity, which is liver toxicity, and allergic type of features. Last one of the 6 classes, integrase inhibitors. Raltegravir and dolutegravir, the names are similar. It has again that vir in them. Exert their action by interfering with integrase, an enzyme that HIV needs to multiply. So the body's ability to replicate is decreased. It's used for the treatment of HIV-1 infections with at least 2 to 3 other antiretroviral agents in both treatment naive and treatment experienced. So people newly starting on treatment, people being treated for a while, but it's used in combination with others. Most common side effects are nausea, headache, diarrhea, pyrexia. It can cause, be cautious with people that already have muscle problems, or people taking medications that increase the risk for myopathy or muscle pain, such as the statins, which we haven't covered yet, but pravastatin. All the statins have a statin in part of their name: simvastatin, pravastatin, atorvastatin. They are used to decrease cholesterol, so that increases their chance of having muscle issues. So that would be a contraindication or something to watch. So that wasn't so bad. That's really what I would need you to focus on these antiretrovirals. If you look through your table 35-2, I just went through it looking about with the food and excreting it in the urine. So I think I told you what you need to know there. The next part, the nurse's role, go over to page 483. The look through your nursing process. Nurses are key in helping with adherence, through education, through collaboration, through teaching them what they need to do. Nurses are key. So if you look at your assessment, of course, perform medication reconciliation, talking about all their drugs, talk about their nutritional history, nutritional deficits, look for food-drug interactions. Whichever antiretroviral they're on, you need to look for, is it one that need with food, without food, does it affect triglycerides, that sort of thing. Assess their readiness to learn. Some people prefer to have things in writing, to have it verbally, to have it demonstrated, or a combination. It gives you a list of your nursing diagnosis. If you look at your nursing diagnosis, it gives you an idea where the nurse needs to focus the care. Look over your planning. Now, when you get down to nursing interventions, there are the little lightning bolts next to several of them. Pay attention to where the lightning bolts are, and that's some of the key things for nurses' role that you need to focus on. On page 485, it discusses opportunistic infections. Just the first section here is HIV infection advances. Patients are more vulnerable to infections and malignancies, and these are called opportunistic infections because they take advantage of the opportunity offered by a weakened immune system. That's what I need you to focus in on there. Go over to page 486. Occupational exposure to HIV and post-exposure prophylaxis. If you have not heard this word before, PEP is post-exposure prophylaxis. If you've had a percutaneous, notice it's not a deep, it's a percutaneous, not blood to blood. If you've been stuck with a needle of some sort that has been exposed to the HIV, human immune deficiency virus, and then they give you a post-exposure prophylaxis. Each facility you go to will have a post-exposure prophylaxis. You need to be familiar with the fact of what this is. On table 35.4, it gives several different drugs, not that you need to know all these drugs, but see that it's a combination kind of look to see what classes they may be in of those 6 classes that I gave you. Over here, HIV prevention. I skipped over here. Page 486, antiviral therapy in pregnancy. When initiating antiretroviral therapy for women of reproductive age, the criteria for starting therapy and the goals of treatment are identical for those other adults and adolescents. So keep in mind, pregnancy does not stop management. You still need to treat as if, regardless of whether they are pregnant. On the second column, it has for HIV-infected pregnant patient who is not on antiretroviral agents or has not started therapy should be initiated for prophylaxis of perinatal transmission. It says here the zidovudine as a component of the regimen is recommended when possible. ART may be delayed until after the first trimester. So those are keys to know with the pregnancy and antiretroviral therapy. The goals for breakthrough or early institution of antiretroviral therapy leading to a 96% reduction in HIV. And make a note there, number 3, medical male circumcision reduces the risk of female to male sexual transmission of HIV by approximately 60%. That is significant. And that is all you need to cover in chapter 35, and that is the end of my lecture.